National Heart Center. सँगसँगै उहाँले अहिले he has founded the Kathmandu Institute of Child Health, KIOCS. This non-profit organization was created to address the pressing healthcare needs of the children of Nepal through a widespread, affordable, and multifaceted approach. यसैगरी अर्का chair हुनुहुन्छ Dr. Bhoj Raj Adhikari is a medical doctor, currently acting as an associate professor of internal medicine at NAMS. He is also the director of Puspanjali Hospital, Chitwan. He is the immediate past president of Bharatpur Hospital and also past VP of NHRC. अब यो आजको हाम्रो पहिलो plenary session तथा 17 को 5औं plenary session health and equity यो सेसनलाई अगाडि बढाइदिनु हुनका लागि म चेयरहरूलाई हार्दिक अनुरोध गर्न चाहन्छु. Thank you so much. In the meantime, I request everybody to gather in the hall. We are all set to begin the first plenary session of the day. Thank you.
यो रेकर्डिङ हो डाक्टर साहब हैन बोलाइदिनु हुन्छ एकजना अनलाइन हो हुन्छ यो मार्क चाहिँ अनलाइन हो हजुर हजुर उसले बोलाइदियो उसको बायो भन्दैन बोलाउन सक्दा बोलाइदिनु उसको बायो भने उसकोबाट सुरु अनि प्रभाकर पनि हुनुहुन्छ Alright, okay, alright, good morning everybody. Myself Bhagwan Koirala and Dr. Bhoj Raj Adhikari, we would be co-chairing this session, very important panel discussion in this important meeting of Nepal Health Research Council. We have very eminent speakers this morning, and if anybody can call people who are on the garden taking tea, maybe it would be useful for them. Let me invite the first speaker who would be online today. We will be presenting virtually, but I'll introduce him. The speaker is Professor Mark Harris. Mark Harris is a foundation professor of general practice since 1990 and an executive director of the Center for Primary Healthcare and Equity at University of New South Wales in Sydney since 2005 till 2023. His high-quality research into the prevention and management of chronic disease in primary care has informed various policies and practices with relevant Commonwealth and state departments, RACGP, primary health networks, health service for disadvantaged groups, non-governmental organizations, and international networks. He currently leads trial of community health workers, extending care into community, which is such an important work, and an implementation trial of web-based interactive shared care plan for cancer survivors. He has been on several National Health and Medical Research Council guideline groups, including most recently for alcohol, on its Prevention and Community Health Committee, and numerous grant panels, including most recently for Center of Research Excellence, I'm sorry. So with this introduction, this is a very important talk, and I would like to invite Professor Mark Harris to present the lecture. And our technical team would, transmit this virtually at this time.
Thank you very much for inviting me to speak at the 10th National Summit of the Health and Population Scientists in Nepal. My name is Mark Harris, and I'm a primary care academic with the Centre for Primary Healthcare and Equity here at the University of New South Wales in Sydney, Australia. I'd like to acknowledge the traditional owners of the land that I'm on. I'm on Camaragal land here in Eora Nation in Sydney, and pay my respects to Aboriginal elders past and present, and also to any First Nations people listening today. Today I'd like to talk about four main topics: the importance of self-management, the evidence for their impact and implementation of self-management support in disadvantaged and vulnerable populations, and the relevance of self-management support in Nepal and other low and middle income countries. Chronic conditions are the main cause of death worldwide. Most of the premature deaths occur in low and middle income countries, and the rates of death and premature death in low and middle income countries are increasing. The chronic care model is an evidence-based model of care for people with chronic conditions. It contains a number of elements that work together to facilitate better quality of care. One of the most important components is self-management support. Self-management support can be defined as the decisions and behaviours that patients with chronic illness engage in that affect their health. The goals of self-management are to develop self-esteem and confidence in people to enable them to make good decisions about their health. Simply providing patient education is not enough to enable a person to actively manage their condition. Here is a typical journey. Jeff has a relatively unhealthy lifestyle for years and has a family history of diabetes. Finally, it starts to catch up with him and he has an acute episode requiring treatment in hospital. This leads to a journey where he is supported by his healthcare team to learn how to actively self-manage his condition so that he can continue to live an active and healthy life with his diabetes. We know from research that we have completed that a positive encounter with a health professional around the time of an acute admission can trigger engagement with the self-management process. It can be any health professional, and it is a journey of acceptance of their long-term condition. It helps to improve quality of life and to prevent readmission to hospital. This table reports the findings from a systematic review which we conducted in 2006 and has been more recently updated. It shows that overall, self-management support improves outcomes across a range of outcomes, including adherence to guidelines, medication changes, physiological measures of disease, risk behaviours, satisfaction, function and knowledge. This recent meta-analysis compares a self-management intervention to a control for patients with chronic respiratory disease. It shows positive effects on outcomes related to health-related quality of life and also the number of all-cause hospitalisation days. What are the components of self-management support that make a difference? This systematic review examined the effective strategies that were involved in self-management interventions. These were the strategies that were most likely to be included in effective interventions. On average, interventions included at least 5 of these 9 interventions. Transfer of information, enhancing problem solving and decision making, active symptom monitoring, stress or psychological monitoring, enhancing diet, medication management, enhancing physical activity, goal setting, action planning, and of course smoking cessation. However, implementing self-management programs in low socioeconomic, Indigenous and ethnic minority groups is a bit more complex. It's important that in these groups to consider the social context and health system in which self-management support is being provided, in addition to the skill of individual patients. Without careful tailoring, in fact, self-management support can sometimes make the social gradient worse. In other words, the gradient that shows that outcomes are worse in low socioeconomic groups than high socioeconomic groups. And this is because both because of differential uptake of self-management support related to educational background, etc., and the impact that intervention has in low socioeconomic minority status communities. So we've found this in some of our own research. In a study in diabetes management in a disadvantaged community, we found that high ratings of doctor communication actually enhanced self-monitoring of blood glucose for people with type 2 diabetes, where the patients were confident to begin with in their self-management. However, in patients that lacked health literacy and were not confident, it could actually make them worse. In another, we found that the factors influencing self-management and the engagement and uptake of self-management really occurred across 4 levels of the socio-ecological model shown in this diagram. So at the individual level, things like health literacy and motivation were important. At the interpersonal level, family and friends and the relationship between patients and their medical providers. Organisational level, it was about affordability and access to care. And at the community level, culture and the resources available in the community were important. Community health workers have an important role to play in self-management support in low-income and culturally and language minority groups especially. This systematic review showed that community health workers delivered self-management support effectively for individuals and groups, including helping them to make action plans, helping motivate, problem solve, providing guidance in self-management, with support either given on the phone, online, or in person. And these roles can complement other roles that community health workers might be playing, for example, in care navigation. But they do require training, especially specific techniques in behaviour change. So this is a case study from Sydney. I've changed the name, of course. Vidya's was born in Sri Lanka and came to Australia about 5 years ago as a refugee. She developed type 2 diabetes and had an ulcer on her leg. She doesn't have access to Australia's National Health Insurance Scheme because of a visa category. And her mother and auntie had diabetes, both had amputations prior to her death. Now she would benefit from self-management support, but this needs to consider what diabetes means to her and her family, especially in the context of what's happened to her mother and auntie. And it needs to be based on relationships that are developed over time. Education, goal setting and care planning needs to take account of her education, her language, her cultural beliefs and practices. And it needs to be provided in collaboration with other providers and other organisations within the community. There's evidence that self-management support interventions are generally effective in low and middle income countries, leading to improvements in physiological indicators, patient self-care and quality of life. However, these studies have tended to be in small population groups or small areas with little evidence that they've been scaled across their health systems. So, turning to Nepal, I want to make a few comments about chronic disease self-management in Nepal. Chronic conditions, of course, are important in Nepal, with evidence of increasing mortality, especially from cardiovascular disease, diabetes, and chronic respiratory disease associated with high rates of smoking and increasing physical inactivity and overweight. This has been recognised in the National Action Plan for Non-Communicable Diseases, which emphasises multi-sectoral action to reduce the risk of chronic diseases, but also to strengthen health systems' capacity to provide comprehensive, integrated and equitable care. So this is a case study of a woman in Nepal from an ethnic minority community, and she has a long history of smoking, a pack per day for the past 35 years. She has early onset of chronic respiratory disease, but this was only diagnosed after 10 years, after seeing multiple providers. And there was also a conflict between traditional and Western approaches to her condition. And this arose for a variety of reasons relating to her culture and practices, but also access to effective assessment and management. This has been studied by Uday Yadav, who examined facilitators and barriers to self-management in his doctoral studies in rural Nepal. And he found that these operated, again, as I mentioned previously, at the